The scientific rationale for the study and to use hyperthermia is based on preclinical findings that we have a sensitization of tumor tissue to chemotherapeutic agents by heat. So the temperature range we achieve is 40 to 43 degrees and this Celsius, and this is exactly the temperature range where these kind of drugs are more efficient in tumor tissues compared to normal temperature. In our previous report in Lancet Oncology in 2010, we summarized the results after a follow-up time of 34 months in 341 patients randomized to neo-adjuvant chemotherapy alone or to neo-adjuvant chemotherapy combined with regional hyperthermia, in addition to the best local treatment, which is surgery and radiotherapy. And the findings at this time was that local progression-free survival and disease-free survival was already significantly improved by the combination, and the response rate in terms of complete response and partial response was significantly better for the combined arm. Even more important, the progressive disease, the percentage of patients who progressed during treatment or shortly after the treatment or died, was significantly lower in the combined arm compared to the neo-adjuvant chemotherapy alone arm. Now on this meeting, it was very important to show whether or not these results after a follow-up time of 74 months are sustained, or in addition, what happens with overall survival, which was at the time point our previous analysis not significant different. So what we found now is, and this was really striking, is that the median overall survival for the combination arm was doubled compared to the neo-adjuvant chemotherapy alone arm in years. That means we have a 6 years difference. But this is formally due to the shape of the survival curves. If you see the curves, you will understand it. More important is that the long-term outcome at the different time points, let's say at 2 years, 5 years and 9 years, are sustained and significant different in favor of the combination arm. So the total results of this presentation here was that we have a new characteristic of hyperthermia. Is no more explained simply by increasing drug efficacy. There must be other mechanism involved in this type of action. So the quality of hyperthermia now is more described as hallmarks of hyperthermia as I defined it. And there will be another presentation on this meeting tomorrow on the hallmarks of hyperthermia. I give you the summary of this in terms of what is affecting the trial outcome, what I presented today. So first of all, we have evading DNA repair. That means if an agent like ifosfamide is inducing double-strand breaks, they usually should be repaired by a repair system. But it has been shown now in the recent years that the homologous recombination repair system is completely blocked by hyperthermia. So this makes a lot of sense now if you have the action of these drugs and they are increased in their potency and in their efficacy simply by this mechanism. But this would not explain the overall survival benefit. There must be, as you look in the survival curves, also an aspect for immunology. And what has been long time before discovered is that by heat you're inducing heat shock proteins, and our own lab in the consortium of other departments have shown preclinical findings that hyperthermia induces heat shock protein. These heat shock proteins are chaperones. They can bind tumor specific antigens and present them after released out of the cells to the dendritic cells or antigen presenting cells, APC, and these cells then present these tumor antigens or neoantigens to T cells. And by these cytotoxic T cells activation, you have an indirect vaccination process going on which fights against the tumor tissue in the body. Now this is very fascinating, but it's speculative, because so far we don't have any clinical data on this. But most recently, in this group of patients we treated in the phase 3 trial, we collected over 130 biopsies from these patients and looked what's going on with the tumor infiltrating lymphocytes in the tumor. I must say I'm not going too far with these results because they are submitted and not published yet, but what we found, and this is clear from now, the infiltration of TILs is greatly enhanced compared to the state before you start the treatment. So we don't know if this is activation or the lymphocyte migration of TILs in the tumor is the process which is induced by hyperthermia and chemotherapy. We don't know if these cells are exhausted, they just stay there, but they are not functioning. And it would be the next step to show, and this is what we are working right now on, is are these cells now reactivated and exhaustion is gone and they become active against the tumor. If this final step will also be shown by clear results, immunotherapy has another partner, which would be the potential of regional hyperthermia to the tumor. The combined treatment, of course, causes, as always, toxicity. And I'm separating now the toxicity coming from the chemotherapy, which is not increased at all. We don't see any increase of the conventional drug toxicity we observe when we use the drug alone. There's only one significant difference in the toxicity profile, which is neutropenia, which is more and significantly enhanced in the combined treatment. This is due to the following. In our study, we had a lot of retroperitoneal abdominal large tumors, greater than 12 centimeters median. So we have a targeted heating field to the tumor, but we cannot exclude the bone marrow of the pelvic. So indirectly, this is a documentation that we increase the drug efficacy in the tumor, but unfortunately also the drug efficacy in the bone marrow, which is of course then shown by and documented by the higher neutropenia. But I should add, we have no septic disorders, and we are not having any death, which is toxicity grade 5. But we have an increase in this, as I said, grade 3, 4 neutropenia. All of these neutropenia patients are solved by adjuvant giving of granulocyte factors. And I would say the other aspect is the hyperthermia-related toxicity, which has nothing to do with hematological toxicity. And here we have, in the beginning, there was a learning curve. We had discomfort in patients when they lay in the applicator design, which are annular-phased applicators. They get some discomfort, and this was in the beginning more than 40%. Now we are down to less than 20% of this discomfort. But in the paper we described in the Lancet Oncology, all these kind of side effects were was tolerable, and it was not stopping the treatment, which is very important. I think this question whether or not hyperthermia is specific working for soft tissue sarcomas is a very important question for the future, because we have chosen the sarcoma types as a rare disease because this is ubiquitous emerging on the human's body as a disease. You have head and neck sarcomas, you have pelvic sarcomas, you have abdominal sarcomas and extremity sarcomas. And the effort was now to see in the phase 3 trial as a proof of principle it's working. And since all parameters were positive, all endpoints, the study is a clear proof that we can use regional hyperthermia combined chemotherapy in this disease as a new treatment strategy. But more important is that this is absolutely not specific for soft tissue sarcoma. The general information is, and which is much more striking, that this kind of treatment can be applied to any abdominal mass of tumor, which is ovarian cancer. There are some studies in phase 2 running. But more important, we have a pancreatic cancer study, a phase 3 study, which is called HEAT, Hyperthermia European Adjuvant Trial, where we have, after resection of the pancreatic carcinoma, we give the standard European 5-cycle of gemcitabine, and in the control, in the experimental arm, we combine an intensified chemotherapy, which is gemcitabine cisplatin, with regional hyperthermia. This study is open in Germany and has over 50 patients now randomized, but we need 350. So we need a lot of interest from the community, we need from healthcare institutions, we need support from the governmental part, and of course for reimbursement, because we are very limited in the number of university centers who are equipped with this technology. And I must say it's really easy to employ, and we would help as a center in Munich for other centers, but we need this kind of team science, which is the best choice.